All right, it looks like people are funneling in, so we'll get started because I know time is precious these days. But I wanted to introduce Dr. Danielle Ransom today, who is going to be giving us a presentation for our Performing Arts and Sports Health Grand Rounds. A little bit about Danielle. She's a board-certified clinical neuropsychologist and subspecialist in pediatric neuropsychology in the Institute for Brain Protection Sciences at Johns Hopkins All Children's Hospital. Dr. Ransom leads the inpatient and ambulatory traumatic brain injury neuropsychology consultation service and co-leads the multidisciplinary concussion clinic. She's an assistant professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. She also co-leads the Concussion Initiative Lab, at Johns Hopkins All Children's Hospital. Her multidisciplinary research investigates precision health paradigms to optimize recovery from concussion. Dr. Ransom is a fellow of the Sports Neuropsychology Society, where she also serves on the board of directors and is a consultant to the National Hockey League and the National Football League. As a former collegiate varsity athlete who now chases around 2 kiddos in her free time, Dr. Ransom is an advocate for safe play and lifelong participation in sport. And so Danielle is going to take it away and talk to us a little bit more about this very important topic for our athletes.
Thanks, Andrea. Thanks to everybody for having me today. I'm going to spend the next 45 minutes or so chatting about sport-related concussion. And so, I know we have a range of folks here today with different backgrounds. So I wanted to try to span, the areas of interest and make sure that I'm not too pedantic, but also not too advanced as well. So happy for any feedback as well. So objectives today is to just discuss the role of the multidisciplinary team in sport-related concussion management. We'll discuss evidence-based multidimensional evaluation and management strategies, as well as navigating the complexities and different ethical considerations that come up in concussion care. So as my disclosures, I am a consultant to the National Hockey League. I'm on the Sports Neuropsych Society Board of Directors, and I do receive some consulting fees from a small private practice. All right, so we'll just talk a little Concussion 101 to start off, and then we'll go into managing the injury and discuss, strategies from sideline to recovery for typical injuries, as well as advanced evaluation and management considerations, particularly when symptoms are persisting longer than we would expect them. So defining sport-related concussion. So we define it by, understanding that it's a type of traumatic brain injury caused by a direct blow to the head, neck, or body that results in an impulsive force that's transmitted to the brain, occurring specifically in sport and exercise. And so this then initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow changes, and inflammation that can affect the brain. Signs and symptoms may be present immediately or evolve over minutes or hours, with many symptoms resolving within days, but can also be prolonged. And so a lot of the slides that I'm referencing here, even if you are familiar with concussion, the latest international consensus on concussion in sport was held in October 2022 in Amsterdam, and the papers were published last summer in the British Journal of Medicine, or British Journal of Sports Medicine. And so this is a meeting that typically happens every 4 years, and it's an international group and multidisciplinary group that gets together to review the previous 4 years of literature to update recommendations for management of concussion. This year, or in 2022, it had actually been 6 years since they had met in Berlin in 2016 because of COVID. And so the slides are going to go through the updated definitions, as well as some other important considerations that came out of that meeting. So we know with sport-related concussion that we're not seeing abnormality on standard neuroimaging studies such as CT or T1 or T2 weighted MRI. But in the research setting, there might be abnormalities that are present on functional MRI or with regard to blood flow or metabolic imaging studies. And so those aren't ready for prime time yet, and we don't quite know what those mean. And so, the science just isn't there to apply it to clinical practice, but I'm hoping by the time of the next meeting, we'll have a little bit more concrete info on that. But we know that concussion results in a range of clinical signs and symptoms that may or may not involve loss of consciousness. So loss of consciousness used to be in the definition of concussion, and now we know that happens in less than 10% of injuries. So it's something that obviously, if it's present, fast tracks you to a diagnosis, but the majority of injuries don't demonstrate that. So clinical signs and symptoms can't be explained solely by, but can occur concomitantly with drug, alcohol, or medication use, and or other injuries such as cervical injuries or vestibular dysfunction, or other comorbidities such as psychological factors or coexisting medical conditions. So this is a conceptual definition, admittedly, and doesn't provide specific diagnostic criteria, but that's been left to the ACRM. And so mild traumatic brain injury, their consensus statement came out last summer as well. And these diagnostic criteria were recently published and, hope to be, unifying this definition as well as the concept behind the injury remains aims of both the concussion and sport group and the ACRM. But the ACRM definition involves a diagnosis when we go through these steps. And so I think it's important to, if you're not familiar with this, to read the paper, take a look, because it really does help define some of those muddy waters when we're going from mild to moderate TBI, and put some specific time limits, for example, on GCS. And, while those aren't always available, it's helpful to kind of know if we're seeing a GCS of less than 13 and it's happening within 30 minutes, it still can fall within the realm of mild TBI or concussion. But if it's persisting beyond that, then we're considering more moderate to severe injuries, depending on, other factors at play. And so another important piece here is that there's now a neuroimaging qualifier. And so we know that if neuroimaging is abnormal, the qualifier of mild TBI with neuroimaging evidence of structural intracranial injury can be used. And when it's completed and found to be normal, the same qualifier can be used, but just without neuroimaging evidence of structural intracranial injury. And concussion can be used interchangeably with mild TBI when neuroimaging is normal or when it's not clinically indicated. So the incidence rate of concussion, we know that with regard to sports, we're seeing 4.17 per 10,000 athlete exposures. The highest rate of injury, as you would guess, is in football with 10.4 per 10,000 athletic exposures. In the NCAA, the highest rates are men's ice hockey and women's soccer. Overall, we know that 70 to 90% of all traumatic brain injuries fall in that mild category. So, while these aren't chronic injuries, for most folks, these are prevalent injuries. So, I know we are used to working with a lot of folks with these chronic impairing conditions that are lifelong, and many traumatic brain injuries are. Concussion and mild TBI usually don't fall into that category, but it's important to know about them because we're going to see these patients. So 10 to 20% of all TBIs are sport related, and falls are the leading cause of ED visits for TBI in children aged 0 to 4 and adults over 65. And sport and rec related TBIs are the leading cause of TBI related ED visits in children and teens. All right, so managing sport-related concussion, super important. I'm not, some groups who I speak to, I'm preaching to the choir, others I'm trying to convince. So this is a little bit more of a convincing slide. But acute care after injury is associated with lower symptom burden and can lead to shorter recovery duration and return to activity. What if that doesn't happen though? So, if somebody's not cared for or evaluated after an injury, they could worsen the injury. So they could continue activities, they could exacerbate symptoms and, misattribute what those symptoms are coming from. If they're continuing to play or they're misdiagnosed and they're at increased risk for a second impact, which most likely would lead to additional injury and prolonged recovery, but in rare instances can lead to some catastrophic outcomes. And repetitive impacts while injured increases risks for long-term neurologic conditions down the line. Poor school and psychosocial outcomes. So we know that these symptoms can impact learning, performance, interactions with peers. And so persisting symptoms also increases risk for depression, anxiety, and sleep disturbances. And again, persisting symptoms are most likely to come about when symptoms aren't treated acutely. So you kind of create this snowball effect. Also, the legal and ethical concerns, the potential for litigation in the context of state laws. In the US, in every state, there are now mandated versions of a when in doubt, send them out concussion law, where athletes can't return to play unless evaluated by a qualified healthcare professional. So there are some legal concerns as well. Signs and symptoms, obviously loss of consciousness or responsiveness, lying motionless on the playing surface, falling unprotected to the playing surface, disorientation or confusion. These are all things that we're observing, right? So these are the signs that, you're a bystander, you're observing them. Dazed, blank or vacant look, seizures or convulsions, slow to get up after a direct or indirect hit to the head, unsteady on their feet, balance problems, falling over, poor coordination or wobbly, or a facial injury. Symptoms of concussion that somebody might feel, so headaches, pressure in their head, balance problems, nausea or vomiting, drowsiness, blurred vision, sensitivity to light and noise, low energy, not feeling right, neck pain, changes in emotions, as well as changes in thinking. And so I have the reference to the concussion recognition tool on here, which is an updated tool that came out of the Amsterdam consensus. I'm not exactly sure what format it's in right now. I know it's been an app in the past, but definitely worth looking into, less so for us as professionals, unless you're on the sideline. But it can be helpful to just kind of tick through what symptoms are present and helps with decision making as well. So red flags when you may need to seek a higher level of emergent care. If any of these signs are present, neck pain or tenderness, seizures, loss of vision or double vision, loss of consciousness, increased confusion or deteriorating conscious state. So just becoming less responsive, more drowsy, weakness or numbness in more than one arm or leg, repeated vomiting, severe increasing headache, increasingly restless, agitated or combative, or a visible deformity of the skull. So those are all would warrant, emergency care to rule out something else going on. So concussion legislations in the US, as I mentioned, all 50 states now have return to play legislation. And that began in 2009 in Washington State with the Lystet law. All right, so switching over to management of sport-related concussion. So there's a number of tools, as I mentioned. So we know the concussion recognition tool helps assess for the visible clues of suspected injury, as well as symptoms and just general awareness. And then the SCAT has been updated for both children and adults to the SCAT-6. And so these are looking for immediate assessments such as observable signs, GCS, cervical spine assessment, coordination and oculomotor screen, and then a memory assessment and Maddox questions. Off-field assessment includes athlete background, symptom evaluation, cognitive screening, coordination and balance, as well as delayed recall. And there are some differences for children as well. So in the post-acute assessment, this is new following this latest consensus. So previously we just had the concussion recognition tool and the SCAT in their different iterations. We now have what's called the SCOAT, the Sport Concussion Office Assessment Tool. So why the SCOAT? Because the SCAT, the reliability and validity decreases significantly after 48 to 72 hours. So folks were using it a bit inappropriately beyond that time point. So they developed an ambulatory tool that can be used. We're still learning about it. There's no studies that have been done on it yet, but it combines the primary areas that we're interested in. And so for those of us who see concussion regularly, this may or may not be something that could be helpful to your practice, but for those who are less comfortable, it definitely makes sure that you're checking the boxes and covering the domains that we know based on research are of interest. So obviously symptoms, cognition. And so actually backing up to symptoms, the most common are headache, head pressure, photophobia, and phonophobia, and just general reports of not feeling right. With regard to cognition, we can see some medium to large effects during the first 24 to 48 hours. With smaller effects for up to a week. And so as a neuropsychologist, this is obviously something I'm interested in, but it remains to be determined which measures are the most sensitive and specific, or that differentiate, those with concussion from those with controls. And so the majority of athletes who do experience some neurocognitive decline during that subacute post-injury phase can typically be identified without baseline data. So that's important to remember. You don't always need the baseline test. But, looking at that cognition, is really important as one of the few objective measures that we actually have. Vestibulo-ocular assessments, the VOMS is really common, and that relies on symptom provocation, including headache, dizziness, fogginess, and nausea in the subacute setting. So looking at smooth pursuits, horizontal and vertical saccades, near point convergence, horizontal vestibular ocular reflex, and visual motion sensitivity. That measure has pretty good sensitivity within the first week, but not much is known after that. Some additional areas that we're now looking at, so obviously the neuro exam, but adding into that is looking at autonomic nervous system functioning. And so particularly heart rate variability is a domain of interest that we are now considering and exploring more as a potential marker. Balance, so the modified balance error scoring system is great. That it involves tandem and a dual task gait measure, as well as looking at mood. So we know that depression and anxiety can spike, following that acute phase of injury. And then finally looking at exercise stress tests. Okay, so as I mentioned, the SCOAT, I'm not going to go into depth here since I covered the domains, but if you're interested, it's available, and there's some good literature on that from the British Journal of Sports Medicine. So care plans, when we're managing injuries as a multidisciplinary team, we often consider some of the myths that are out there, or parents will often come to us with these questions. So we used to, I'm not going to go through all of these, but in general, our principal strategy is to gradually ease folks back into activities of daily living. And what the science says is that sooner than later is ideal. And so we're doing it to the degree that symptoms can tolerate, but we're not doing things like waking the patient up several times a night. We're not making them rest until they're completely symptom-free. If anything, 1 to 2 days tops. We're not necessarily limiting screens or reading, in the first 48 hours, maybe, but, after that, we can proceed with some moderate exposure, some light reading. We're taking breaks. We're trying to strike this balance between not too much and not too little, and trying to find that sweet spot on a day by day or even portion of the day basis seems to benefit folks the most. No social activities, that's, again, definitely a myth, and some moderate activities that are more subdued with an exit strategy are ideal. And no physical activity, that's something that we've taken off the table and know a lot about now. So, after that 48-hour mark, some light physical activity progressing through heavy non-contact activity until cleared is recommended. So we used to operate in a way where, athletes were injured and, we would basically cocoon them until they were better. But then, you keep somebody in a dark room for multiple weeks on end who's used to being physically, cognitively, socially active, and you're just going to have a depressed individual with persisting symptoms. So we don't do that for any other condition, really, and concussion is not an exception here. So prior to Amsterdam, this is just kind of expanding on the rest and activity. We did know that, an initial period of rest might be important, and that excessive physical activity could temporarily exacerbate symptoms, and similar with cognitive activity as well. Based on the most up-to-date literature, we know that strict rest until symptom resolution is not effective, and meta-analysis supports starting subsymptom threshold aerobic exercise for adolescents 2 days after sport-related concussion, and that can shorten recovery by about 4.5 days. Again, with regard to cognitive activity, we do want to limit that activity, but only really within that first 48 hours. And then we are gradually easing them back in. So, this doesn't mean that they don't need academic accommodations. They certainly do. I'll talk about that in a minute. But thinking about things from a subsymptom threshold standpoint. So returning to sports and returning to learn. So we know that, and we already knew that symptoms and severity early in injury are predictors of length of recovery. And that we rely on these subjectively reported symptoms to inform our returning to learn and returning to sport strategies. We had some data that early physical activity and prescribed aerobic exercises were beneficial, and that the management of returning to activities, including school and sports, should be tailored to the individual. So now we know that by and large, it's nothing massive has changed there, except we have a lot more data supporting those statements. So continued play and delayed care after concussion are associated with longer recovery times. And similar returning to learn and return to school or return to sport strategies are effective, across ages, across genders, with minimal differences in recovery times. And healthcare providers need to account for pre-existing and post-injury factors like depression, anxiety, migraine history that can impact recovery. And most athletes, about 93%, are returning to learning without academic support within about 10 days across all age groups. And recent trends do indicate longer durations for athletes to become symptom-free and return to sports. And that's not to say injuries are getting worse or we're hitting harder, but likely due to evolving management strategies. We have, a lot more tools in our tool belt that we're using, a lot better sensitivity and specificity indicators across those tools. And so we're taking a lot more factors into consideration. Okay, so returning to learn is super important in managing concussion. I'm not going to go through all of these steps, but basically, the return to if you're familiar with the return to sport, we're adapting that model to the classroom. And so getting kids involved, first as passive observers as we're getting them back into the classroom, potentially with, a partial day, and then gradually stepwise increasing that participation as they're able to tolerate, and then modifying accordingly. Similar with return to sport. And so, we are obviously progressing through these steps, not necessarily waiting till they're symptom free, but we can start soon after with the non-contact components, so steps 1 through 4, and then gauging symptom response to those activities before we're progressing to the next step. So length of concussion recovery. So as I mentioned earlier, about 93% of athletes have full returning to learn without accommodations at that 10-day mark. The mean days until symptom free is about 14 days. About 19.8 days are until returning to sport fully. However, it is important that anywhere from 15 to 50% can take 1 or more months to recover. So that's a pretty big range. And we're still understanding the various predictors of why that might be. So we know that initial symptom burden is the strongest predictor of recovery. Continuing to play is also a predictor of recovery. So you're staying in, you're more likely to get hit again. You may not have all your senses about you, and you're definitely not playing as at the level that you normally would if you're truly concussed. Delayed access to healthcare providers can delay recovery. Pre and post injury factors such as mental health, migraine history. There's some mixed data on female sex and younger age cohorts that just haven't been as consistent in the literature. Based on the most recent consensus statement, given some overlapping confidence intervals based on the meta-analyses in terms of male and female recovery, they're stating that there are similar recovery patterns, but I can say anecdotally from our clinic data, that's not what we're seeing. We are still seeing females in general take longer to get better across ages. And these overlapping clinical profiles are really important to think about, but so overall strategies for management involve monitoring for those exacerbated pre-injury conditions, counseling regarding expectations of recovery, really dialing in sleep hygiene, and implementing subsymptom threshold physical activity. These other domains are what we're considering in a multidisciplinary exam. So looking at vestibular, cognitive, fatigue, anxiety and mood, headache, migraine, ocular, and understanding that a lot of those overlap. And so really individualizing care planning after concussion is important because most patients will have features of many of these profiles. And, if you've seen one concussion, you've seen one concussion. So there are some population-specific considerations. I'm primarily a pediatric provider, but I do, as my disclosure says, some consultation with professional leagues as well. And so across these groups, educating about symptoms, the recovery timeline, and the importance of adhering to protocols is crucial. And each protocol should be adapted to the individual athlete's progress and particular needs. So in peds, some important considerations are that, developing brains and bodies may be more vulnerable to the effects of impact exposure. So, one impact to an adult might, the physics are going to be different in a child's body. They might require a more conservative management with a more gradual return to activity, depending on symptoms and specific considerations. And returning to learning really should involve the medical school partnership. So those are some specific pediatric concerns. Moving on to college, amateur, and professional sports, not to say these things aren't happening in peds, but minimizing symptoms to return to play quickly, and risking further injury. Certainly the stakes are higher in those settings. There can be a greater impact of the injury to mental health, that tends to come out more in a highly competitive environment. However, the benefit is that these athletes often have a network of healthcare professionals and multidisciplinary teams that improve their access to care, and support multi-level return to sport decision-making. So there's lots of layers of protection here. Adult civilians, you know, for those of us who are adult providers, you know, thinking about other health issues that can complicate recovery, you know, pre-existing medical concerns, cardiovascular issues, mental health, balancing recovery with personal and professional lives. You know, as adults, I know we all have very stacked schedules and demands, and you know, I often think, like, you know, if I were to sustain an injury, we went skiing last week, and I was thinking, you know, if I were to get injured here, like, I genuinely do not know how my family would function for a couple of weeks. And honestly, I would be that person trying to, you know, not follow my own advice of balance, and I would likely be pushing through it and causing symptoms to go on longer. So I would imagine that most of us would be in that same position. Access to specialized care and resources for recovery, you know, social determinants of health, guiding that access, as well as, you know, the need for a more, instead of returning to learning, more of a return to workplace accommodations, as well as community resources. So we have about just a couple minutes to kind of breeze through something that's really important to think about. So persisting symptoms after concussion. If you can take one thing away from this talk, it would be that, you know, if I never heard the term post-concussion syndrome again, I'd be a happy person. You know, there's a lot of reasons why that term's problematic, but to boil it all down, it's just really non-specific and has been shown to promote iatrogenesis. And so persisting symptoms after concussion rather identifies that there are certain specific symptoms that are persisting. And by identifying those specific symptoms, we can promote access to treatment and intervention to support those symptoms. And so you take a condition that is very vague and nonspecific in post-concussion syndrome and bring these symptoms more into treatable territory where we know they respond well to interventions. So if 15 to 50% of folks are taking longer than a month to get better, 1 month is that mark where we consider symptoms persisting. That's a pretty broad range. And so knowing what to do when a patient like this is, you know, you're interacting with them or you're conceptualizing treatment is really important. And so, you know, we think about persisting symptoms as those that aren't improving or some that are worsening. And, you know, they may be related to pre-injury or, you know, resulting factors from the injury. And they could be present due to the injury itself, but often are due to the other biopsychosocial factors as well. These symptoms cause distress or disability more days than not. And these symptoms interfere with partial or full return to typical activities such as school, work, sport, and other social roles. So in dealing with persisting symptoms, we're wanting to evaluate and identify the specific symptoms that are persisting. Again, diagnosing post-concussion syndrome does not drive treatment or recovery. And common persisting symptoms include headaches, visual disturbance, vestibular dysfunction, anxiety, and insomnia. And so really just by ditching the post-concussion syndrome and identifying somebody as having headaches, that seems a lot more treatable through referral to neurology than, or, you know, physical therapy if we're talking musculoskeletal tension, than just labeling something, you know, as PCS. And so I could go through each of those and it just seems a lot more manageable than this vague terminology. I'm going to skip through some of these. Okay, so considerations. So in persisting symptoms, you know, we often see headache, sleep, and mood are three of the primary targets when folks are dealing with persisting symptoms. And I'll just put in a plug for the Living Concussion Guidelines, which are guidelines that were developed in Canada. And they're a great reference if you haven't looked at that resource yet. Vestibular dysfunction is also a really common and area that we can intervene. And so active rehab for symptoms like dizziness, neck pain, or headache is often recommended early. So this is even before we get to the persisting symptoms phase, but there's data showing that even 5 to 10 days after injury, if these symptoms are on deck, going ahead and making that referral, initiating care can be beneficial. So other factors that impact recovery, just like most healthcare condition or health conditions, barriers to care access and social and environmental inequities. So thinking about the social determinants of health and the various systems that patients and families are nested in and how those systems interact to either promote or serve as hurdles to accessing care and implementing care recommendations if care is accessed. All right. And so as far as future directions go, we really need to standardize the definition and diagnostic criteria. I think we're heading in the right direction. Tailoring evaluation protocols and psychometrics for current tools. So those tools I mentioned earlier, the CRT, the SCAT, and the SCOTE, really getting the psychometrics of those to better understand their diagnostic capabilities and prognostic capabilities is important. As well as, personalizing our treatment and recovery strategies. All of us who work in rehab know the importance of individualized care and management. So personalized rehab and recovery plans are so important. That slide that I pulled up with the various, it looked like the flower with the various patient profiles, you're going to have a mix. And so knowing what's important for that family, what they have on deck, what social determinants are involved, will, on the clinical side, allow you to better serve the needs of your patient. From a research standpoint, that's something that we need to be better about, looking at these various layers and how they interact. The evolving role of technology. This is a new and not necessarily new, but it's an exciting area that I hope, it's not going to replace the need for folks to do the work, but I do see neuroimaging and biomarkers as being a really important place to move to in the future. So much of this injury relies on subjective reporting, and with the various contributions to persisting symptoms that are not due to primary concussion, we want to be able to offer our patients the best and most specific advice that we can in order to guide treatment and tailor the recommendations that we're making. And so, imaging and biomarkers is a way to do that. Wearables and sensor tech for real-time monitoring of, injuries happening, but also recovery, as well as telemedicine and other digital tools that can increase access given the prevalence of smartphones and other technologies. So there are some great resources if you're not familiar on the CDC website for kids. So CDC Heads Up. There's some great discharge planning paperwork for providers in the ED to give to families. These are just some screenshots of some of the documents that we've set up with RED. There's a school letter, we've tailored our own, but this is a great resource for providers who just want a simple checkbox. And those are linked here. So I have about 3 minutes before I need to head out. So I'm happy to field a quick question or two. Otherwise, you can feel free to reach out to me via email.
Thank you, Danielle.
Absolutely.
If anyone has any questions, feel free to put them in the chat. or if you want to unmute and ask quickly before we finish up. We'll have to invite you back next time so that we can hear this IndyCar data update maybe.
Yeah, so one of our research partnerships down here is we're working with the IndyCar medical and engineering teams, and we published a paper on 13 drivers over 3 years last spring in JAMA. So we looked at impact exposure in the car as measured through, there's a data box in the chassis, as well as the translated forces to the earpieces. And so we compared that to post-season oculomotor exam as measured through a goggle device, the iPass device, and didn't see any changes or associations. And so there's a lot more that we want to do there. You know, tying that a little closer to crashes and looking at those protocols and looking at more drivers over time. So we're getting into their data over the last 7 years, which is the amount of time they've been using that goggle device, as well as pulling in some other data points as well. But it's a lot of data that has required a lot of processing and cleaning, and more than we had anticipated. So we're grateful for the partnership, and they're great people. So it's an exciting collaboration.
That's awesome. John Shipley put in about regarding tech, how valid is the iBox? And do you see that coming to clinical practice sideline to help diagnosis at all?
So, you know, as far as diagnosis, you know, I don't know a ton on the science there, but I do know that CHOP has been using the iBox. So I think we're still understanding how these tools work, how sensitive and specific they are. The iPass goggles that are used in IndyCar do have some good data differentiating concussion from controls. We just don't know a lot about how those measures function over time, and, you know, in these various populations. So, you know, in a motorsport driver whose visual motor, oculomotor functioning is superior because of how they've trained and what they're training, you know, how looking at the relative change and having a baseline there is something that series has implemented, which is great, because I'm sure if they compared it to mine as a soccer player with little need for you know, specific oculomotor response time as an outside midfielder, it would be very poor. So, you know, we're knowing who you're looking at, what group you're comparing to, what you're calling normal, is definitely an important part of the science, but, you know, not the most attractive part of the science. It's, you know, when we're talking about this and to lay people, they think, you know, all that's assumed, but you know, these are important measurement components and constructs that anytime you're trying to assess change, it's important to take into consideration.
Great.
Awesome. Well, I have to run to clinic. But thank you guys so much for having me. I really appreciate you all being here, and feel free to reach out to me via email if there's anything else that I can do for you.
Great. Thank you so much again.
Absolutely. Bye, everyone.